Good morning from my side. Thank you very much, Professor Philippatos. I would like to thank Professor Philippatos and Associate Professor Karamassis for this very kind invitation to participate in this very interesting session. I will try to stay short, focused, and give the main aspects of how to treat diffuse disease. And I think that we have to realize the steps. And first is to identify the problem. We have 4 different patterns of coronary artery disease. We have focal lesions, diffuse, serial, and mixed pattern. And we have the tools to identify in which case our patient matches best. First of all, lesion length. If we are talking about focal lesions, we have to see that the lesion is less than 20 millimeters. And after that, physiology. We can use different parameters, non-hyperemic values, the FFR values, or angiography-derived values. And you can see the numbers that define where our patient really belongs. And now, in our case, that we're talking about the diffuse disease patients, then we have a lesion length of more than 20 millimeters. We have an FFR pullback progressive decrease without focal pressure drop, and a PPG index that was very well talked before, a PPG index of 0 to 0.45. And of course here it looks like that angiography-derived FFR takes more and more place in identifying this diffuse disease in order to avoid any problems in the future. And why we should always check where our patient best matches. Because it also goes with plaque morphology. We have seen from the studies from the Center of Alst, from Carlos Collet, that when we're talking about focal lesions, then we're talking about more lesions with a lipid-rich plaque and thin cap tightness, and all these characteristics that define whether this patient will have an event or not in the future. So we see all these characteristics in focal lesions and not in diffuse lesions. And of course, we have to guide the problem. We have to guide our patient in the best possible way. We can see here how we treat our patient in focal and tandem diseases. We will stay focused in this patient with diffuse disease. In the patients with diffuse disease, we have to be ready to realize that PCI looks unlikely to be effective at removing the diffuse disease. And the pre-PCI, when we make our plan, pre-PCI simulation seems less likely to predict the post-PCI results. And the consideration of further medical therapy or surgical intervention should be in the mind of the interventionalists rather than the PCI. And of course, we have several post-PCI implications. We have to be ready to see that post-PCI optimization is unlikely to deliver an acceptable result. And we have to consider accepting these suboptimal results and maybe drive our patient to better pharmacological therapy. Just a case where we use the angiography-derived FFR. Of course, here, we don't have diffuse disease. It's likely a patient with tandem lesions, but I have this case just to show how we can use the angiography-derived FFR in a patient that comes to our cath lab with diffuse disease. Here we can see a lesion in the proximal part of the LAD, a lesion in the mid-segment, and if we do the angiography-derived FFR, we take these very nice values. Here you can see a value of 0.65 at the distal part of the LAD, and here looks it's getting more and more interesting. Why? Because here we can predict whether we fix the lesion or not, the post-PCI result that we will receive for our patient. So here we see that, so here we can see that if we make a PCI in the proximal part of the LAD, then we will take a value of 0.84. if we just treat the proximal lesion of the LAD. And here you can see that if we just treat the distal lesion of the LAD, then we will take a result of 0.69. And at the end, if we treat both lesions, then we will take an FFR value of 0.92. This is a very intellectual technique, and it provides us with all the aspects that we need in order to treat our patients and realize the pattern and realize the FFR values throughout the whole vessel. So this is an algorithm on how to treat our patients in all these different scenarios that we discussed in all these previous lectures. I think that in our case, we are focused more in the right part of the algorithm. We see that patients with diffuse disease always keep in mind that optimal medical therapy or doing a GABAT looks better. And if in case we decide that the patient refuses these two methods and needs to go for the revascularization, of course we have to do an imaging-guided PCI. We have to avoid overstanding, and we have to be ready to see that the values that we have after our result will be suboptimal, and we should be ready to accept these values and after that optimize our medical therapy in the best possible way. So identify the different patterns of coronary artery disease, using coronary physiology for the guidance, and avoid treatment with serial stents in diffuse disease. Thank you very much.
Dr. Milkas, any question and comments?
Thank you. Congratulations, excellent presentation. Now, in a physiology guidance, we have a lot of modalities. And as interventionalists, we are a little bit confused. Which is now is the modality we have to use with more evidence from the literature?
Look, as we know,
except FFR.
Yeah, except for, of course, for the angiography-derived FFR values, commercially we have these three major companies. It's the CutWorks with the AngioFFR. This was a case from the CutWorks and the AngioFFR technique. We have the QFR and the VFR. Different modalities. We have a very nice talk before of how each modality uses a different way to calculate the final result of the FFR. But now we're talking just, we have a big trial coming from China that was an event-driven trial. So this is the only trial that we have so far that shows a difference between angiography, just we use angiography or we use angiography-derived FFR in terms of MACEs, and there is an ongoing trial from the AngioFFR company with 2,000 patients. This is the target to participate in the study. This is a study that is still recruiting patients, and I think that the results will be released in 2 years or more. So I think that what we need is validation, as you said. And I think that after this trial, we will have the validation we need in order to guide our patients in the best possible way.
Any other comment or question?
If I may. Yeah, please.
Congratulations for your presentation. I think we approached the diffuse disease in a rather simplistic way. In which term? We have two different types. We have the chronic diffuse disease, mainly with calcified plaques, and we have the rather soft plaque diffuse disease. And in the future, I think we have to approach this pattern in the way that the oncologists approach cancer. And I'll make myself more clear. We may need to treat those patients with soft disease, soft plaque disease, with high doses of statins, in case that this disease may actually improve at some stage in the near future, and then reassess those patients. And patients with calcified disease, chronic calcified, which will not respond to treatment, is these patients that we have to treat in a more invasive way. This is my view, actually.
Well, it's another important issue, the composition of the plaque and what we should do. Of course, at this point, we estimate flow limitation or
Yeah,
imaging that we get, but we don't go inside the plaque. And things may change. We'll see. If there's another comment, thank you all of our speakers, our